Hello, this is David Wallace with PV Reporter, and we're here with Dr. Angela Fleischman at ASH 2015 in Orlando. And Dr. Fleischman is the Assistant Professor, Department of Medicine, Hematology, and Oncology at UC Irvine. Dr. Fleischman, your research has been focused on MPN patients. Tell us a little bit about your recent publication that involves inflammation as a driver of clonal evolution in MPNs.
So my research focuses on the role of inflammation in myeloproliferative neoplasms. Inflammation is very high in MPN patients, particularly in patients with myelofibrosis. And it's thought that the high inflammation drives a lot of the symptoms that patients feel, such as the fatigue, the night sweats, the fevers. But I believe that the importance of inflammation goes well beyond just the symptoms. Believe that the inflammation plays a role in disease initiation itself, as well as promotes the expansion of the mutant clone in MPN. And what we've previously shown is that when you remove an inflammatory protein called TNF-alpha in model systems of MPN in the laboratory, that removes the selective advantage of the JAK2 mutant cells. So we found that the JAK2 mutant cells love to grow in the presence of inflammation, whereas normal cells will be suppressed by inflammation. And then when you remove the inflammation, the mutant cells are no longer able to do better than the normal cells, so they decrease. So thinking that the importance of it is that inflammation may be an important target, therapeutic target in myeloproliferative neoplasms, not just for symptom relief, but also for impacting the neoplastic clone itself.
Okay, all right. One of the key points that I saw in that article, there are quite a few actually, but if you have a prior history of any autoimmune disease, then your chance for basically contracting an MPN becomes much greater. Can you talk to us a little bit more about that?
So yes, that's actually a very important point, and brings up the possibility that high inflammation may actually precede a myeloproliferative neoplasm, and it's possible there is a familial predisposition to acquire MPN. There are families where multiple members have MPN. In general, it's not a familial disease per se, but could it be that the predisposition, people who have a more inflammatory, they respond to could people who have lots of inflammation and have a more tendency to mount a more robust immune response, could that be the predisposition to acquire a myeloproliferative neoplasm and drive the emergence of the mutant clone? So for example, someone could genetically just be prone to more inflammation, and when they have more inflammation, then if they have a JAK2 clone, that clone will expand and cause disease, whereas in another person who does not have a lot of inflammation, in them possibly a JAK2 clone would never expand and cause clinical disease. It would not have a selective advantage.
Okay, and I noticed within that article there were mention of a few specific illnesses. Could you mention a few of those and why those might be prominently mentioned?
Probably, in terms of autoimmune diseases, for example, things like rheumatoid arthritis, which is characterized by lots of inflammation, and lupus, which is characterized by lots of inflammation as well. So I think that the autoimmune diseases that are characterized by, I guess you could say, overt inflammation or chronic inflammatory states, I think is the predisposing factor. I don't know whether particular autoimmune diseases themselves would predispose somebody to acquire an MPN per se,
Okay.
or it's just that a situation of chronic inflammation does that.
Okay, and this is perhaps a little bit off the chart, but I don't often see the discussion of nutrition and supplements and that sort of thing as far as reduction of inflammation. Now, we certainly have our medical or drug targets. Are there any natural methods or anything in that area that would help one to reduce inflammation?
In terms of diet and those sorts of things. So unfortunately, we don't really know, it's difficult I would probably just say a healthy, reasonable diet, exercise, living a healthy life is probably my suggestion.
Okay.
What's interesting is actually ruxolitinib is JAK inhibitors are also being developed for autoimmune diseases.
Okay.
Ruxolitinib, I think of its major reasons for its effect in MPNs is reduction of inflammation. So that's not really what you're asking, but ruxolitinib reduces inflammation.
Okay.
And JAK inhibitors are used for autoimmune diseases,
Okay.
as well as NPN, which is also a very interesting correlation.
Sure, okay. Wanted to kind of, this leads into your latest research abstract that you're presenting here at ASH 2015. And it's a blunted response to the anti-inflammatory cytokine IL-10 contributes to excess TNF production in MPNs. That's a mouthful.
Okay, so I'll try to explain it in a clear way.
Okay.
So we know that TNF is overproduced in patients with MPN. So the purpose of our study is to try to figure out why. What is the mechanism? Why do MPN patients make more TNF? So we started to focused on one signaling pathway. So TNF is classically made when monocytes monocytes are a type of immune cell that we have. When our body senses bacteria, it can sense bacteria and other pathogens because our cells have receptors that recognize conserved features of bacteria or viruses. So it allows us to sense when we see an invader. And that mounts a signaling pathway that then releases inflammatory cytokines. So that's how we mount a fever, that's how we get rid of infections. And we need to be able to, when we see an infection, mount a response, and then we need to turn it off. Because if we didn't turn it off, then we would just be chronically inflamed and chronically have a fever. When you saw a bacteria, you would never turn off that fever response. So there's a long way around the introduction, but in response to one of the what's called LPS, which is a lipopolysaccharide, which is a component of the bacterial cell wall, our monocytes make a lot of TNF. And so we thought, well, this is the classic way that monocytes can make TNF. Let's see if when we give MPN patients monocytes LPS, will they make more TNF? And yes, they do. And so then next wanted to see, why do they make more TNF? We found that it's known that when you treat normal people's monocytes with LPS, they make TNF and then they turn it off. And it's a very short pulse, and it's a very well-defined period of time that is conserved among humans. It should, all normal controls should have this turning on and turning off.
Okay.
So we looked at the tempo of TNF production in normal controls versus MPN patients, and in normal controls, as expected, we see TNF turning on, and then very quickly their cells turn off TNF production. But in MPN patients, they turn on TNF and then they don't turn it off. So it's a persistent TNF production. So figured that it was the reason why they have a lot of inflammation is they're unable to turn off the signal that tells their cells to start making TNF. And one of the important feedback mechanisms, the way that normal monocytes turn off TNF is by they also turn on production of IL-10, which is an anti-inflammatory protein, which then signals back to the cell, signaling through the IL-10 receptor, tells the cell to stop making TNF. So we thought, well, okay, maybe it's a problem with IL-10. Maybe they're just not making IL-10, but we found that they're making a lot of IL-10. So then looked downstream of that saying, well, oh, they're making a lot of IL-10, but maybe they're just not responding to it. So they're not able to sense the anti-inflammatory signal. And that's what we found, that in response to IL-10, so IL-10 is able to turn off TNF production when we add it to normal monocytes, but in MPN patients, it's unable to do so. And exactly why MPN patients have this defect in the ability to sense anti-inflammatory proteins is unclear, and that's what we're trying to work out at this point in time. Whether it's a direct consequence of the JAK2 mutation, whether the MPN clone itself causes bystander monocytes to have this abnormality, or the third possibility is, could this be the predisposition to acquire a myeloproliferative neoplasm? Could the inability to turn off or to respond to anti-inflammatory stimuli, is this something that's just a genetic feature of patients with myeloproliferative neoplasm and not a consequence of the disease, but predated their disease? I don't know which possibility it is, but those are things that we're trying to work out.
So another piece of the puzzle, perhaps. As regarding the IL-10, is that perhaps a therapeutic target in the future, or?
So that, yes, that's one possibility. And actually, so when we add IL-10, when we add excessive amounts of IL-10, so supraphysiologic amounts of IL-10, the MPN monocytes are able to respond. So they're unable to respond at normal lower levels, but when we just blast the system, they are able to respond. So that suggests that maybe administration of IL-10 could possibly be thought of as a therapy for MPN. Actually, IL-10, recombinant IL-10, is actually being used for treatment of autoimmune diseases, particularly, to my knowledge, in autoimmune diseases that affect the gut. So yes, that could, something that's currently being investigated in another disease could potentially then be applied to MPN, and IL-10 would be a reasonable thing to do.
Okay. What do you see as some of the highlights at this year's show, and just a quick summary so far?
In terms of for clinical, so new clinical trials in MPN, of course, there are a number of new JAK inhibitors that will likely soon come to market, pacritinib and momelotinib. So it's just interesting to see data on those. Other novel sort of mechanistic treatments in MPN, the telomerase inhibitor is something very interesting. And it just would be interesting to see how that works in larger clinical trials in MPN. Other drugs that are of interest, yesterday there was a talk on the PRM-151, which is an anti-fibrotic agent.
Okay.
So I think that all of those, the new novel targets in MPN are very interesting, and of course it takes quite a while from the science to the point when a patient can actually receive drugs. So it's quite a long process. And then in terms of biology of MPNs, we are starting to begin to understand the mechanism by which calreticulin mutations drive a myeloproliferative neoplasm. So the mutations were identified at and presented at late-breaking abstracts 2 years ago, and now we're just getting publication, or the field is getting publications and some abstracts this Tuesday at the late-breaking abstracts about the mechanism. And what is thought of how calreticulin mutations cause a myeloproliferative neoplasm is it activates the TPO receptor pathway, thrombopoietin receptor, or MPL, which is also mutated in a small fraction of MPN patients. So it brings to light that the central theme of myeloproliferative neoplasms is activation of what I believe is activation of the MPL pathway. That's sort of the central theme. JAK2V617F also activates the MPL pathway. So we have all of the very common mutations in MPN, JAK2, calreticulin, and MPL, all sort of what they have in common is they activate the MPL pathway.
Okay. And I know there are tons of other mutant genes, but we don't have time to go into all of those, so I appreciate you giving us the highlights there. And Dr. Fleischman, I want to thank you, first of all, for being one of our early consulting contributors to PV Reporter a couple of years ago in the early day. And thanks for spending time with us at ASH. This is David Wallace with PV Reporter.
Thank you very much for this opportunity.
Okay, thanks again.